I have no financial disclosures to make. And I want to provide a land acknowledgement. The University of Kansas Medical Center acknowledges that the KU Edwards campus resides on the traditional homelands of several tribal nations, including the Kickapoo, the Kaw-Kansa, the Osage, the Dakota, the Lakota, the Nakota, Shawnee, and Wyandot peoples. So the learning objectives for today is to discuss a collaborative partnership to help improve health outcomes among underrepresented pregnant populations, and to describe an innovative community-driven approach to reach underrepresented pregnant populations with educational programs, resources, and support. So this is a brief overview of Pioneer Baby and the eMOMS study, and both of these initiatives are to improve pregnancy and birth outcomes among reproductive age individuals in rural and urban Kansas. So let's start off by providing a little bit of background on gestational diabetes. That rate is increasing nationally, and it currently sits at about 7 to 9%. And of those people diagnosed with gestational diabetes, about 20% have a subsequent diabetes diagnosis after pregnancy. There are several risk factors that lead to gestational diabetes, such as advanced maternal age, having a family history of diabetes, being non-white, having had previous gestational diabetes, and having a high pre-pregnancy body mass index, or BMI. Pre-pregnancy BMI equal to or over 30 is a particular risk factor for gestational diabetes, and 3 out of 10 US women have pre-pregnancy BMI equal to or over 30. So both these conditions combined lead to adverse pregnancy and birth outcomes that are listed here, such as pregnancy loss, preeclampsia, cesarean section, congenital anomalies, reduced lactation prematurity, maternal and infant death. So complications of gestational diabetes are particularly increased for rural people due to limited access to obstetrical healthcare services, which leads to an increased likelihood of low birth weight babies and preterm deliveries. There are very long drive times to hospitals, late entry into prenatal care, and low breastfeeding rates. So all these factors combined lead to an increasing trend in maternal morbidity and mortality with rural individuals, individuals of color, and individuals with low income at increased risk of pregnancy-related death. When you look at the first set of bars in this graphic, between 1987 and 2020, the US pregnancy-related mortality tripled from 7.2 to 23.8 maternal deaths per 100,000 live births. This rate is even higher for non-Hispanic Black women and for Hispanic women compared to non-Hispanic white women. So bringing this all back to our critical access hospital that we started working with in Southwest Kansas, Kearney County Hospital, which is a full spectrum hospital that had about 200 deliveries a year in about 2015, 2014. They now sit at about 340 deliveries a year. That's a very high number for a rural critical access hospital. They serve about 11 counties to people of about 22 nationalities. And they experienced a high rate of pregnancy complications, including gestational diabetes. And when we looked into that further, their diabetes rate set about 11%, which was twice that of the nation at that time. So when we look at Pioneer Baby, we can, in our population of interest, we can divide it up into our work up into 4 phases that are listed here. Phase 1 through 3 took place between 2015 and 2017. And some of the projects that are listed here, we will talk about. And then phase 4, we're currently in with our eMOMS study, which is an intervention program. This is a timeline of the events that took place between about 2015 and 2023, very busy looking slide. The stars at the top are the milestones that we accomplished, and the activities at the bottom of the pink bar in the middle, they led up to each of the milestones. And the 2 arrows in the top, we were working on a KO1 submission with NIDDK, and we were awarded that grant in 2018. The first work that we did was a health assessment of the obstetrical population in Kearney County in Southwest Kansas to learn more about the characteristics and health behaviors of rural pregnant people. We provided a survey that was provided in English and Spanish. We had a fairly high response rate, and the demographics are listed here. low socioeconomic status, and the majority of women were WIC enrolled. Non-Hispanic white was also the majority of women. Well, Hispanic were the majority of women. They also indicated that they had an immediate family history of diabetes. And when you look at the middle graphic, the green and the yellow indicated that their pre-pregnancy BMI was over 25 or over 30. They also indicated that they had very low physical activity. When you look at the second pie chart there, the red and the blue area, more than 70% indicated they led a very sedentary lifestyle. To address the immediate need for high-risk obstetrical care, we developed an outreach, or established rather an outreach clinic, a maternal fetal medicine clinic that was staffed by a maternal fetal medicine specialist with his staff that was in collaboration with Via Christi, Ascension Via Christi Hospital. The physician and his staff flew over to Southwest Kansas once a month and then followed up with telemedicine and shared in the continuing education of local rural healthcare providers. The LGA rate was measured, large for gestational age babies, and that actually went down from 28% in 2015 to 17% in 2018. We also did a follow-up focus group study in the same catchment area because we wanted to gain more in-depth information from rural pregnant people on what they would value in a health promotion program. The sociodemographics were very similar to that on the obstetrical assessment. And the overarching themes that we found is there was limited availability of programs that focus on physical activity, nutrition, and lactation support during and after pregnancy. There was a need for a support group during and after pregnancy. There was a lot of peer education going on during all of our focus group sessions. We concluded with broad community health assessments in 3 counties, Kearney, Haskell, and Grant counties. And basically what happened there is those larger community health assessments corroborated the findings that we already knew from our smaller obstetrical health assessments. The response rate was fairly high at the city and county level, more than 60% at the city level. And respondents indicated that high-risk obstetrical care and weight management coaching lay within their top 5 priorities, and within their top 10 health priorities was diabetes prevention support, professional lactation support, and nutrition and diet counseling. So in summary, our pregnant population had a high pre-pregnancy body mass index, limited exercise, and had a family history of diabetes. Half of respondents were of low socioeconomic status, self-identified as Hispanic. There was limited access to health promotion programs and lactation support services. And the top health priority was in weight management coaching. So there was a demonstrated need for long-term health behavior change. So we started looking into the literature and came across a program, the Diabetes Prevention Program, which is an evidence-based program and reduces the risk of developing type 2 diabetes by 58% through effective diet, exercise, and behavior modification counseling. There's also evidence to support the use of this program to reduce postpartum weight, and evidence suggests that lactation duration is associated with lower incidence of developing diabetes, a reduction of maternal postpartum weight, and it also helps reset that maternal metabolism clock after pregnancy. So then we found a gap in the literature that there were no studies on the role of lactation support that was combined with an efficacious weight loss program such as the DPP to reduce postpartum weight, thereby reducing progression to type 2 diabetes and pregnancy. And so what we did, we combined the DPP with lactation education and support and created eMOMS, which was a 12-month-long virtual program that included individual health coaching. This was part of our KO1, the project that we undertook with the KO1. It was a feasibility, unmasked, parallel, randomized, controlled 3-arm trial. We registered it at clinicaltrials.gov with the overall goal to test the feasibility of a combined DPP-based program in a cohort of rural and urban people with a BMI equal to or over 25, followed during pregnancy through 6 months postpartum. We had 3 study arms. The first arm included the DPP and lactation and health coaching. The second arm included the DPP and health coaching, and the third arm included health coaching only. The program content consisted of evidence-based educational videos on lactation, nutrition, and physical activity that we delivered via Facebook. And the study aims were to quantify interest in the use of this program among a targeted population and to measure weight loss, hemoglobin A1C, and duration of lactation through 6 months postpartum. So as for study eligibility criteria, they were intended to obtain a study population with a low likelihood of developing pregnancy complications. And our recruitment took place between September 2019 and December 2020 in the midst of COVID-19. We screened 100 individuals, randomized 35, and added up with a completion rate of 74%. 26 of the 35 women, individuals rather, completed the program. And the demographic characteristics for all participants are listed on this slide. Most of you are familiar with the consort diagram. For ease of viewing, we kind of cut it in half, so it's easier to read it a little bit. Again, we screened 100 individuals. We assessed for eligibility 62. We randomized 35. We allocated these 35 to each of the 3 arms. We lost some individuals to attrition, and then the analysis is at the bottom graphic at the right-hand corner. As for results, we had small sample size, and so I'll only be able to report the medians and the interquartile ranges for each of the arms. Our statisticians in Wichita helped us with some sophisticated bootstrapping, which is particularly used for small sample size. And we applied that to mean weight retention from baseline to 6 months and to mean lactation duration through 6 months. And we did make a difference with our mean weight retention. As you notice, women in the first and the second arm of the study, their weight retention at 6 months was at 8.9 pounds and 8.1 pounds, whereas women in the third arm of the study, their weight retention at 16 months was 16.5 pounds. Mean lactation duration, we did make a difference, though not so much between groups, but compared to women outside of this program who only breastfeed for about 6 weeks, we still did fairly well with the program. So as for next steps, we completed an evaluative study on intervention uptake that's currently under review. We also completed semi-structured exit interviews with our study participants. That one is currently under review, and we're in the process of completing a main outcomes manuscript. Our next step is a large-scale, multi-site randomized controlled trial testing the efficacy of this program with a larger sample of ethnically and racially diverse rural pregnant populations. Pioneer Baby and eMOMS, true collaborative partnership between some of these partners. They're listed just a few partners here. We had a lot more people that played a role in this, in these projects. And I want to give a shout out to my mentors who are listed here, to our key team members, to administration staff at Kearney County Hospital, Ascension Via Christi, the Kansas Breastfeeding Coalition, the Department of Pediatrics, and of course, all of our study participants and their families. And thank you for your time. Okay.
In your core group, what was the ethnicities that were involved in that?
The majority of women were white, about 65% total, which is still more diverse than where Kansas is at about 74% with white. Then we also had about 16% Hispanic women and about 8% Black women. So we set around the same diversity racially and ethnically as where Kansas sits, though we would like to oversample. Yes. So that was a lesson learned for us for an R1. Yes, it also impacted breastfeeding. Yeah, yeah. Okay, the health coaching did impact exercise, and it impacted breastfeeding as well, lactation as well. Yes.
I personally love PI prerogative. It makes all my days very interesting. Next we have Dr. Lepping. I do want to make one announcement. The lunches have been delivered. Unfortunately, not all the lunches were delivered, so we are making a Panera run right now for veggie sandwiches. So if you would like a veggie sandwich, we may be a little late with those, so hold back. There are meatless salad vegetarian options, but live events, PI prerogative, these things keep you on your toes, and there you go. You just got to keep going. Dr. Lepping, the stage is yours.
That looks right. Wonderful, thank you. Well, thank you for the invitation. My name is Rebecca Lepping. I'm Assistant Professor of Neurology at the University of Kansas Medical Center. And I'm really happy today to share with you the Frontiers funded pilot study that we did looking at music-elicited analgesia and fibromyalgia. There we go. I do not have any financial disclosures other than the funding from this study, which was funded by a Frontiers Arts and Medicine Trailblazer Award in 2019. And because I'm going to talk about music today, I thought it would be important to sort of frame where I'm coming from in this research and why I'm interested in music in biomedical research. So I'm a cognitive neuroscientist and an imaging researcher. I use a lot of imaging tools in my research, and I look at a lot of different anatomic systems, including the brain and kidneys and the lungs, but I'm also a music psychologist and a trained musician. I play the piano and the flute, I compose music, I'm a singer. So I am both a neuroscientist and a musician, and I try to bring together music and neuroscience and psychology and clinical research to understand how music can have an impact on our health and well-being through physiological and neural mechanisms. That said, I am not a clinician. I'm not a music therapist. I am a neuroscientist, and I'm really thankful to the Frontiers team for providing the infrastructure to help the dialogue between these different, very disparate disciplines, that this research wouldn't have happened without that. So why am I interested in music for health? Who of you like to listen to music? Anybody? Yeah. Anybody play music? Any musicians? Yeah. Does anybody like to listen to particular music to get you into a particular emotional state? Make you happy, rev you up? Yeah. So music has a lot of areas where there's an intersection with our physiology, both in terms of making music, but just hearing music can trigger dopamine response, and also psychology. And music can be a really useful tool across a variety of different health conditions and psychological issues because it has such a widespread network of the brain that's activated. So one of these areas is chronic pain. Fibromyalgia is a type of chronic pain that is a chronic condition associated with widespread pain throughout different parts of the body that's not necessarily linked to any physical injury. People with fibromyalgia have hypersensitivity often. So what to most people would be just a light touch or pressure, someone who has fibromyalgia might experience that as a painful stimulus, right? It could be very painful for them just to feel touch. And this has been challenging for people with fibromyalgia because there's not a visible injury that's associated with that pain. And pain is a very subjective experience. It's difficult to get that across to someone else, how it feels to you. But there's a tool that we use called quantitative sensory testing, which is a testing battery with Dr. Andrea Chadwick, who's one of the collaborators on this project, is the local expert in quantitative sensory testing. We have these devices that we use and a very standardized way to collect the data so that it's replicable and responsive, and documented that this hypersensitivity is a real thing that people are experiencing, which has not always been the case, unfortunately. So we use these devices in the quantitative sensory testing in the study. And so I'll tell you a little bit about these devices. The one that you see on the left in the darker picture is a handheld device. The bottom part is a hand grip, and there's a hole in the back that the participant can put their thumb into. And then inside the top part is a rubberized stopper that comes down and puts pressure on the thumbnail. Anybody ever squeeze their finger in a doorway? Yeah. So this is a painful stimulus, but it doesn't actually injure anyone. We have this all controlled by a computer, so the pressure and the duration are all very standard. The second device there is in the picture with the hands. So this is what we call a pinprick stimulator or a von Frey filament. So it is a thin wire inside a shaft that looks sort of like a pin. And when you press that against the skin, the wire retracts into the shaft. So it, again, causes a pinprick pain, but doesn't break the skin and doesn't harm anyone. So we use these two devices to get an objective measure of pain. But then why are we interested in music? Well, in several research studies, there have been really interesting effects showing that music listening reduces pain. In surgery and orthodontic procedures, people have required less anesthetic, which is a big deal because anesthetic can be very dangerous. The postoperative recovery period is faster with music listening, and orthopedic rehabilitation outcomes are improved. But this is an acute pain. So in chronic pain and fibromyalgia, what's the story there? Well, there's been some very tantalizing research that just a 5 to 10 minute listening intervention with people with fibromyalgia improves their mobility. They are quicker to stand up from a seated position after this intervention. And then looking into the brain using functional MRI, they actually discovered that it modified brain activity in the descending pain pathways in the brain. Which leads us to the question of music is accessible for people. Music is something that is universal. Everybody listens to it. Is this something that people who have fibromyalgia could use as a preventative tool in their own pain management arsenal to, when they know they're going into a situation where they expect to experience pain, could they just listen to some music and potentially experience this pain reduction? And now we come to this pilot study, this initial study. We were looking for what are the physiological mechanisms in the autonomic nervous system that underlie this pain response. We were the first study to use objective quantitative measures of pain using this quantitative sensory testing technique. And importantly, most of the work that I just shared, the studies about music and analgesia, compared music listening to silence or standard of care. So was that just because people were being distracted by the music? Is there anything special about music? And that led us to this study. We have published this work in Frontiers in Pain Research, so if you're interested, you can go and check that out. But I'll go through the methods and the results now. This was a very small study. We got our award in 2019 and had to stop our study early due to COVID restrictions. But we had 9 participants in this study, all adults with fibromyalgia. They were all women. And they came in to do this music listening intervention to hopefully reduce their pain sensitivity. We measured their pain tolerance and threshold objectively using these quantitative sensory testing methods. We also measured their autonomic nervous system reactivity with ECG, measuring heart rate and heart rate variability. Participants came in on 2 separate days. One day they had the testing during the audio listening condition, and on the other day they had the testing done in silence. Participants were randomized to listen to either classical music or nature sounds control in their audio condition. And we were basically looking for any analgesic or pain reduction effects. So when the audio condition had less pain response to silence, we hypothesized that the music listening condition would have a greater analgesic effect over that simple auditory distraction of the nature sounds. Music research is difficult because it's often fraught with bias, and the way that we feel about music, we like music, we expect to have a particular outcome. And so we used several strategies in this study to try to minimize that bias so that we would know if the results that we were seeing would be really due to the music and really due to the effects. One of those was to make sure that the researcher was blinded, which means they didn't know what the participant was hearing. The testing took place in a small room with the participant and the researcher both in the room. And so to make sure that the researcher couldn't hear what was going on, the participant wore noise canceling headphones, the researcher wore earplugs, and then we had these different audio tracks identified by number only. And we also included tracks of silence so that even when the participant was sitting in silence, the researcher couldn't tell that they weren't hearing anything. Also, to try to enhance the rigor of our reporting, we included a lot of information about the particular music that we chose. This was all selected to be relaxing music, so it was slow, about 60 beats per minute, primarily consonant harmonies, so nice sounds, not a lot of dissonance, sustained melodic phrases, and we didn't have any lyrics or heavy percussion, which would have been too energizing. In order to try to control the music experience across participants, everybody heard the same pieces in the same order. Similarly, we had the nature sounds. These were also professional recordings of essentially a microphone out in the forest, hearing the wind through the trees, hearing the sounds of the water in the river, birds singing, but no added music was included in these. Again, all participants heard the same recording in the same order. And the purpose of this was to really control those analgesic effects that were not related to the music, like distraction. So I'll start with our pain results. This is a busy slide, but I'll walk you through it. So first we have temporal summation. Temporal summation is the difference in pain response from one pinprick of that pinprick stimulator and a series of 10 of them in a row. And you can see that our participants in the music group had greater pain response than the nature group overall. But we also saw that there was a main effect of the session, which means that during the audio listening, there was less temporal summation compared to the silence across the board. And we had an interaction between the groups. So the nature group actually showed more of an analgesic effect, more pain reduction when they were listening to the nature. And the music group didn't really show much difference. The other pain condition that we had with the mechanical pain tolerance with the thumb squishing device didn't really have any difference between groups or between sessions. And for heart rate, we actually didn't see any significant differences, but we saw a pattern of results that was what we would have expected if there was analgesic effects on the autonomic nervous system. So the dark line at the top of these graphs is baseline when they're just sitting there. I haven't started listening to anything yet. When the sound comes on, then there's a reduction from baseline in the heart rate. And then when the pain testing starts, there's a further reduction. And I'm not sure if you can tell the difference in the colors here on the music group on the top. That was actually more of a reduction when they were listening to the music, and the nature group was switched. So they had more of a reduction when they were listening to silence. It's difficult to draw conclusions with such a small study, but we did see an effect of cognitive distraction, or just being distracted from experiencing the pain in both of those audio conditions. So both in the music and in the nature, the auditory stimulus was effective for reducing that immediate pain response. We saw the analgesic effect in the nature group, but not in the music group. And although we did randomize participants, this very small study, we actually did have some group differences in some features of fibromyalgia that could be contributing to these results. So we had anxiety symptoms were higher in the people in our nature group, and pain was higher in our music group. But these are tantalizing preliminary evidence, and our next step is to submit an NIH R1 grant to do a larger trial and really dig into some of these other measures that we think might be important, including anxiety, and also inter-individual differences in music experience, music enjoyment, because we think that might make a difference too for who's going to be to get benefit from music listening. And because I'm a neuroscientist, I obviously want to look at the brain and do some functional MRI testing with this quantitative sensory testing. So thanks to everybody who made this work possible, our team, our study participants, and Frontiers for the funding. Thank you for your time.
Know you're talking about it being double blinded. My question is, when somebody's listening to music, lots of times they'll sway or they'll tap their feet or, were there any things like, did you tell them they couldn't do that? Or, because I'm thinking that's part of the experience of listening to music that might help you relax. So I was just kind of curious if that was anything that you considered in your study.
That is such a wonderful question. So we did ask the participants, they had instructions at the beginning of the track and instructions before the study started that it was really important for the researcher not to know what they were listening to. So we did repeat that multiple times throughout the testing, and participants they tried to keep from, tapping to the beat and things like that. It wasn't very rhythmic. We didn't have a lot of percussion or a heavy beat in the music, which sort of minimizes that to some degree. And we actually did not, so the researcher did not know what the person was hearing. It didn't come up. And then during the analysis, we also kept that blind. Yes.
So it sounds like distraction is also very important.
So do we need to think about a combination perhaps of music and distraction?
Thanks for that question. Yes, distraction is very important for pain management. It's a very powerful technique that's often used for pain management, which is why we felt like it was very important to have that active control of something besides music, because the anecdotal evidence is music is really important. And, as a scientist, I think it's really important for us to understand what is that active ingredient. Is it the music? Is there something additional about the music? Or is it just distraction? And if distraction can be as powerful, or if we use it in combination, I think that's really important to think about.
Awesome. Thank you, Dr. Lepping.
Thank you very much.
Right.
Okay, we are now ready for our first transition to lunch. Couple reminders for those that joined us a little later. Please exit through those doors by the beverage stations. Go left for the lunches. We just discovered that we were not brought utensils for the salads, but those are being brought with the veggie sandwiches from Panera. So if you want a salad or a vegetable sandwich, please hold back to the bottom of the yeah, so I got a text that those are being packed up and leaving College and Quivira, so there'll be a few minutes away. So please grab your lunch and proceed to one of the concurrent sessions straight down the hallway. The restrooms are to your left, right by the red chairs and the wood paneling. And again, room 120, that session has been moved to room 130. It will not affect the online people. For those joining us virtual, on the agendas that were emailed out with the Zoom links, you'll see a Zoom link underneath each session. So just please click on that Zoom link to open it up, and you'll be able to participate in whichever session you like. So thanks, everyone. Please enjoy your lunch and see you at the next session.